Hello, everyone. Thank you for joining me today to have this conversation about goals of care and advanced planning. Hopefully, after our little workshop today, you will be able to take something with you to be able to strengthen these conversations that you'll be having with your family physicians and with your healthcare teams. So first, I'd like to go through the land acknowledgement. Red Deer PCN acknowledges that we work on Treaty 7, Treaty 6, and Métis ancestral lands, the gathering place of many Indigenous people. We honor our relationships with one another. So here's a little bit of the agenda. I'm going to chat a little bit about why it's me today that's talking to you about goals of care. And then I'm going to ask you some questions just to sort of set your mindset in the right place to have this conversation. We'll talk about different questions to think about in preparation for having this type of conversation with your family physician or healthcare provider. We'll talk about an example, and then we'll talk specifically about the different goals of care designation as you may see on your green sleeve. So here's a little bit about me, and it might answer your question a bit as to why it's me having this conversation with you and what do I really bring to the table. And so basically my personal experience and my professional experience has led me to become quite passionate about having this conversation with more intent, having people think about a conversation about goals of care. And really the goal is just to have you thinking about it so that you're not in a situation where you're forced to have the conversation. So basically my nursing experience, as a registered nurse, I started as an ICU nurse. Now in the intensive care unit, we see the sickest of the sick. And as a brand new nurse, back in 2007, I experienced a lot of death in the intensive care unit. And so I did this and I had this conversation with many of my long-term care patients, and then again with my supportive living patients when I moved to Red Deer, and then my home care patients, and then now I'm in the PCN, and I am blessed to be able to now have this conversation earlier. It is a different conversation when we have or think about these things prior to anything being a crisis. The other piece I want to share with you is that I do have experience on a personal level with the goals of care conversation. So this beautiful woman is my mother. This was taken at my wedding in 2015. We got married on a beach. We had all our friends and family and loved ones gathered, and my mom, as nervous as she typically is, got up and spoke to everyone and shared her stories about me growing up. And just, you could tell in the picture, just her face is gleaming. Now, if I didn't tell you, 7 years prior to this, she was rushed to the hospital for emergency brain surgery for a brain bleed at the age of 47. At that time, I was a very, very new nurse. And I will tell you that when this happens to you on a personal level, the nurse in you goes away. You are just that family member at that point. And so I can tell you with all honesty that I have been on both sides of the conversation. When my mom had to be rushed into brain surgery, I received a phone call and it went a little bit like this. Your mom has had a brain bleed. We want to rush her to surgery. She has a 50% chance of surviving, and if she does survive, she has a 50% chance of recovering completely from any deficits. We need to know what you would like to do. And that was it. That was the conversation that I had on the phone with the surgeon. And I will tell you that as a family member, the only thing I remembered was percentages and survival and death. This is what you call a crisis. This is what you call no real options. And so at the time, the only thing I could think of is to save my mother. And I really didn't understand anything else that was said in that conversation, nor would I have had the ability to absorb any other information if the surgeon wanted to share any more at that point. I had a goals of care conversation on without even knowing that that's what it was. And I said, please do everything. The reason I am having this conversation with you now is because had we had the opportunity, or if you have the opportunity and the gift of time, it's important for you to have these conversations when you can think clearly about what it is that you really want. What is most important to you? And the question I'd like to put out to you is, if you think about the last 10 years of your life, what do you feel or what do you think that would look like? Because that's the basis of what a goals of care conversation is about. We, as healthcare providers, it's important for us to know what really matters to you and how do you see the last 10 years of your life look like if you had the ability to control it. So I am going to play a video here to just get you thinking about, how you'd like to see that last 10 years of your life. Again, if you could control it.
What will your last 10 years look like? Will you be quick enough for a game of tag with your grandchild? Strong enough to embrace every moment? Will you grow old with vitality? Or get old with disease? It's time to decide. The average.
So it's an interesting question, thinking about those last 10 years of your life, because people don't typically think about it. And so the goal is for you to start thinking about what matters most to you. So where do we start? Well, it's important for you guys to know that you have time right now when you don't have an urgent or emergent situation. But it's also important for you to know that a goals of care designation, when you start to have that conversation, you don't have to make a decision right away, right? Especially again, when you're not in an urgent or emergent situation. You can start like you are starting today, start thinking about it. Also, it's a bit of a misconception that you need to know a prognosis or percentages to begin this conversation. You actually don't need a healthcare provider to tell you how long you have to live or what's the percentage that you will survive. You don't need those numbers to start to have this conversation. As a matter of fact, I would recommend that you start to have this conversation earlier. Now, a conversation about goals of care and what it is that you would want, this may all happen in one meeting, but honestly, It is best that it happens at several meetings with your healthcare team, and that's okay. After this workshop today, you may have further questions. You may want to have a further conversation with your primary caregiver, whether it be your family physician or nurse practitioner. It's okay to have several meetings. There is no pressure at this point in your life to make a decision right away. So here's some questions to ask yourself before having that conversation, before making a decision in terms of goals of care. What's your understanding of where you are with your health and your condition, right? So many of you may have different things that you're taking medications for already: blood pressure, diabetes, osteoporosis, things like that. And very well, maybe very well managed with what your family physician is helping you with what your healthcare team is helping you with. But do you truly understand where you're at in terms of those different things in your healthcare history that are currently being managed? What are your goals and priorities, and what would you like to do as time runs short, right? So it's starting to think about, like that video, that last 10 years of your life. So when I say time runs short, we're not talking about tomorrow. Um, you know, it's hard to prepare for those urgent or emergent situations when life is cut short. But when we talk about, as we approach that time, what are the things that are most important to me? What do I want to accomplish? What are your fears and worries in the future? And I think it's important to have this conversation. And if you have family and loved ones, just start talking about, what are your fears about the future? Some examples of what patients have said to me about what their fears are, just to sort of get your mind thinking. Many patients might fear losing their independence, losing their homes, having to move somewhere and leaving what they have known for their entire lives, maybe losing people. Maybe they fear for their family and their well-being. What are your fears and worries for the future? It's important to be open and honest about those things. And as the video sort of shows, how do you see your next 5 years and 10 years? What does that look like to you? And I think the last question is really important to start to think about. What are the trade-offs you are willing to make? The question is, how much suffering are you willing to go through for the sake of added time? Right? There are many things in the medical world that we offer, and especially coming from an intensive care unit, and I'll talk more about this when we go through the goals of care. There's many things that we can offer from a medical standpoint that essentially may add time to life. But they don't necessarily, these things that we are offering, these medical treatments that we are offering, don't always decrease suffering that might come with it, right? There are risks and benefits to different treatments. And the question is, how much suffering are you willing to go through for the sake of added time? The hope is that if you tell me as your healthcare provider, so if you tell me as your nurse practitioner or family physician the answers to those questions, I'll be able to guide you and make recommendations of the designation that might sit most appropriately with. Although at the end of it, it is your decision. So let's talk about the goals of care. So in Alberta, we have 7 different designations that you're able to sign off on your goals of care. And so I think it's important for us to sort of know a little bit about what these designations mean. Because to many people, they're just letters and numbers, but really they do mean a lot. The other thing I want to do is have that conversation with you from a perspective of you being at home and relatively healthy. I will say that this conversation, if had in a crisis situation in a hospital, might be different. And I'll explain why. So R1. So any of the designations that start with an R stand for resuscitation, right? So R1 is what we call full resuscitation. It means that as a healthcare team, we would be providing everything that we could possibly offer from a medical standpoint to save your life or extend your life. That's the goal of an R1. So what's involved in an R1 is cardiopulmonary resuscitation, which in the picture there is your healthcare team sort of manually compressing your heart to get it started again. Also part of R1 is any artificial ventilation that we need to add. So in the ICU, if you are unable to breathe due to whichever medical condition you are experiencing, if your lungs are not working, then we're able to sort of start that breathing machine to breathe for you. And then any other life supportive measures offered in the intensive care unit. So besides what we see there in terms of CPR and a breathing machine, there are other measures in the ICU that we would offer to, again, try to preserve that life and extend that time as much as possible. Some of these things might be, for example, we have patients in the ICU that might need continuous dialysis. You've heard of dialysis happening 3 times a week, but if someone's kidneys, for example, are not working, they might have a continuous machine doing that. Or if someone's blood pressure is unable to stay at a safe rate because it's continuously fluctuating, you may have medications that would continuously do that. So like a continuous IV medication that would hold that blood pressure. When we're thinking about resuscitation and life supportive measures, the easiest way to think about it is that if we took those measures off, your body itself would not be able to sustain life. And that's why we call it life supportive measures. Now, I want to preface the fact that an R1 in a hospital is different in that you have access to all of these measures right away, right? And when we're talking about survival, there's many things we look at, but one of the most important things is time. The sooner we start all of these things, the higher the percentage of potential survival, along with looking at the rest of your health history and comorbidities. So in a hospital, we could start these things right away, right? You have time on your hands at this point. If you think about an R1 in your home, okay? If your heart stopped when you were in your home and you were in R1 resuscitation, the thing to keep in mind is that you don't have that same time. It will take time for healthcare to get to you in your home. If you're living independently, right, that'll affect time. If you don't have family living with you to activate these emergency services, that will take time. If you are living in a more supportive environment with healthcare practitioners there and a call bell and those types of things, that might speed up the reaction time for sure. But I need you to think about these designations in terms of where you're living and your access to these listed things that are available. Now, when we're thinking about R2, and actually as we think of the designations, we start to take away or not allow certain medical treatments. So when you get to an R2, which is still under the resuscitation level because you're still being offered life supportive measures, you will be receiving all medical treatments, including a breathing tube or a breathing machine to help you breathe, and including the intensive care life supportive measures. But should your heart stop in an R2, we will not be doing CPR. Okay. And that's the decision that one would make based on the questions that we talked about earlier, based on even your spirituality, based on your values. You kind of put that all together in terms of whether or not you would want CPR to be started. Also, it may be worth it to have that conversation about what are the risks of CPR for myself, right? When we think about the act of CPR, someone who has severe osteoporosis, for example, might sustain quite severe fractures from the pressure of CPR. So again, it's weighing the risks and the benefits of that. The other thing to think about is where you're at in terms of your heart history and what your baseline heart function is like as well. Those will all play into whether or not someone decides they want CPR. Now, when we're looking at R3, again, still R resuscitation, we are looking still at being offered life supportive measures that you can get in the ICU, right? Remember, we talked about things like continuous dialysis or continuous medications. But at an R3, the person has decided, again, weighing in on all the factors, that if their heart were to stop, they would not want CPR. They would not want a breathing tube. But other than that, they would like all other medical treatments and surgeries that can be offered. Now, the second sort of options in your goals of care designations are M. So there is an M1 and an M2. M stands for medical care, okay? Many people tend to fall into the M1. M1 means you will get all medical treatments necessary if you are falling ill that can be offered in an acute care hospital. So let me put this into perspective for you. If you were home, not feeling well, having significant trouble breathing, right? And there's no medical treatment available within your home to be able to treat this severe inability to breathe. M1 would be, please rush me to the hospital to get treatment, whatever that may be that they can offer me, up to the limitation of life-sustaining measures, right? And remember, if we go back to it, life-sustaining measures means if we remove those treatments, your lungs would not be able to function, right? So life-sustaining measures are CPR, breathing, artificial ventilation, so breathing tube, and some of those continuous treatments that are offered in the ICU. But anything else medical that can be offered to me in hospital puts you at an M1 level. So what are some of those things? Some of those things are diagnostics. So we're talking about CTs and X-rays, lots of the things that they offer and emerge. We're talking about IV medications and oral medications. We're talking about potential surgery if needed. We are talking about everything that can be offered except for life supportive measures. So those three things that we talked about specifically in the R1 designation. So anything else that falls into medical care would be offered to you. And in a situation where you were feeling quite ill at your home, for example, not being able to breathe, and if I were the care provider that found you there, whether I be a paramedic or a nurse that was working in your supportive living setting or something along those lines, I would immediately activate 911 if I saw that you were an M1, because I know that you would want all medical treatment offered. Now, an M2, again, medical care, still falls under medical care, but it's a little bit of a gray area. The reason I say this is because in an M2, though you do want medical care, I like to put it in a perspective of someone living at home. And we divide it into urgency, right? So someone with an M1, if I came to your door, I would immediately be calling 911. If it was an M2, we'd start to look at options of medical care that can be offered in your home if possible. And if you need to be transferred to the hospital, the goal would hopefully still be to have you go back home. And the other thing is someone can move from an M2 to an M1 depending on the situation. So I would look at the difference between M1 and M2 as urgency. M1, no matter what's going on, we're calling 911. M2, we're having a conversation with your care providers, with yourself, in terms of what we can offer in terms of medical treatment in the home, and that if we are going to go to the hospital, there is a plan in terms of what kind of medical care you're going to receive in the hospital, with the hopeful goal that you could return back home. Now, C1. So when we say the words comfort, sometimes that can be, there could be a misconception in terms of what comfort means. And I want to set the premise and let you know that comfort does not necessarily mean end of life or imminent death. C1 stands for comfort. Comfort level 1 means when we're looking at your goals and we're looking at your values in terms of what you want, your goal is to be comfortable, okay? Comfortable meaning if the treatment that we are offering you is going to cause more discomfort for you. And for some people, that means not being transferred to the hospital. For some people, comfort could mean different things. But I do want you to know that if someone is a C1 or comfort, that does not mean we are taking away all medical care. Similar to M2, we would like to see what we can offer to you in the home. For example, if you're having a quite severe urinary tract infection, what we would try to do then, if your level of care is comfort, is begin your treatment in the home. Knowing with comfort, though, that there is a limitation in terms of what can be offered in the home, right? We don't have the diagnostics, we don't have x-rays, we don't have CTs, we don't have the option for specialists or specialized treatments that can only be offered in the hospital. But we do have lots of access to different medical treatments that may be able to treat what is happening right now. When people talk about comfort, often they think and they look at their overall health, right? Many of us have different health conditions, diabetes, maybe high blood pressure, things like that, that are being treated and are stable, not necessarily cured. So when we're thinking about a C1, we are looking at the whole picture and understanding that there may be conditions that we have that are not curable, that possibly many of the treatments that we have in hospital may cause more risks than benefit. Looking at what would be the recovery period if we did get more treatment, right? It's weighing out those risks and benefits. So many people who choose comfort level 1 are looking at, what are the risks? What would recovery look like for me if I continued with any treatments or things in the hospital? Will it improve my overall well-being? And will I be uncomfortable afterwards? So C stands for comfort. And then finally, C2, again, comfort is still the main goal. It's C2 where you actually have a prognosis. So you've had a discussion with a physician, or your family has had a discussion with a physician, indicating that you have a certain amount of time and you have a condition that is not curable, right? Or you've exhausted the options that would be recommended for you to treat this, and therefore the specialist or the doctor is able to give you a timeline. So a C2 is truly what we think about when we're talking about palliative care, or not palliative care, I want to say true end-of-life care, right? When death is imminent. That is C2. And essentially the focus is on managing pain in the home, managing symptoms at end of life, to try to support dignity and comfort at end of life. That's a C2. So when you're having this conversation, these are the things that you think about. Like I said, there is a difference between goals of care in the hospital and goals of care in your home. Depending on where you're having this conversation, whether it be with your healthcare provider in hospital or your family physician, it's important to talk about how these designations could be carried through differently. Talk about the risks and the benefits, right? Thinking about your entire health history, thinking about all the other health conditions you have, and what are the different risks of maybe receiving some of these treatments or these supportive treatments. It's good to talk about different examples that I talked about here today. What would be the situation if I was at home and a healthcare provider came to see me, or 911 was called? And consider your overall values and beliefs. I think spirituality and plays a role in this conversation in terms of, what it is within your beliefs. Where does medical treatment, where is there a line that you would draw in terms of medical intervention based on some of your own beliefs? It's important to note that the goals of care document is a fluid document and can change when new circumstances or health issues arise. So you have your first conversation with your family physician based on how your health is at that time. Should your health conditions change? Should you get new diagnosis in the future? Should things change in your life in general? Even your environment or where you're living might change. So might affect the access of different healthcare options you might have. It's important to have this conversation again. So goals of care can be updated when there is a change in health condition or circumstance, and really should be reviewed with your family physician on an annual basis. It's important to know that a goals of care designation form can only be signed by a doctor or a nurse practitioner. And here is the form. You may have seen it before. This is what the most updated version of a goals of care designation form looks like. If you don't have one or haven't seen one, it would be important to ask your family physician about one, right? You could see that those are the 7 designations we talked about. And this form would go inside this green sleeve. It is sometimes called a green sleeve. I think people are familiar with the term green sleeve when we talk about goals of care. Now, inside your green sleeve, there should be the most updated version of your goals of care designation form after it is signed by your family physician or nurse practitioner. And also in your green sleeve, it's important to have copies of your other legal documents, your personal directive, your power of attorney, if you have one, and also your will, a copy of your will, if you have one. These can all be put together. And the common place that people put it when they're in their homes is on their fridge. As an emergency service provider, paramedic, if they ever have to come to your home and due to your medical condition, you're not able to tell them where your goals of care is, if you put it on top of your fridge, they will know. And that's the first place that we look as healthcare providers. So before we end the presentation, I do want to leave you today with just a few words from a physician, Atul Gawande. He is a physician that speaks quite passionately about having these advanced care planning conversations. And he's actually very honest about the fact that as healthcare providers, having this type of conversation has not been formally integrated into what we were trained for. And so it is important that we as healthcare providers have these conversations with our patients. And it's important for you as patients to be able to speak for yourselves and have this goals of care conversation at a time when you're ready, at a time when you have had the time to think about what it is that you truly want.
That gap was extraordinary to me. We never imagined to ourselves that there was that life worth living, and that medicine was actually in our neglect and in our unwillingness to ask those questions about what matters to people, that we were actually sacrificing those abilities. And that furthermore, it's not just at the very end that we need to ask these questions. We need to ask these questions from the minute people start needing our help. When you have a parent who's frail enough, where a question comes up of whether they can live at home or not anymore, or where they have other illnesses that aren't going to go away. Being able to ask, what are your priorities? What really matters? Her priority was she wanted to teach. Another person I spoke to, they said, if I can eat chocolate ice cream and watch football on television, that'd be good enough for me. I'd be willing to go through a lot for that. If I can't have that, let me go. It's like the best living will ever. And I tell the story of my dad who had a brain tumor. And I said, chocolate ice cream, football on television, what do you think? Not good enough for him. For him, it was sitting at the dinner table with family and friends. He was an extremely social person, and it was food and talk that was life for him. And his tumor would eventually take that away, and we knew it. and being able to know and have that discussion and to have that clarity that there can be goals besides just living longer, and that
And so I'll end this by saying, let's not wait until end of life to have a goals of care conversation. The basis of goals of care is to really think about what matters most and what is worth fighting for. I challenge you, no matter where you are in your life, to start thinking about this. And that will give you a basis to be able to have better, more informed conversations about goals of care. If you have any questions, you can contact the Primary Care Network in Red Deer. And I do have my email up here. That's ruby.narine@rdpcn.com. Thank you.